2 minutes.
Yeah. You do the introduction, right?
Yeah. I'll do it. I need to replace I have that's it.
I can introduce myself.
I'll introduce what I know from about you. Yeah? It's enough.
It will be enough.
You have 6 ships, 6 ships, 10
10
chickens,
sheep. 6 cats,
6 cats,
10 sheep,
10 sheep.
Yeah.
Okay. And how many
and
chickens?
9 chickens.
Okay. 6, 10, 9. All right.
Yeah. And a wife.
Good configuration. Yes. All right. Yeah. Your introductions.
Yeah.
All right. Yeah. Hello. Good morning, everyone. Morning. How are you today? Fine. Have you had breakfast? Yes? Or are you so sleepy after breakfast? Because your voice is very, very, how to say?
Low.
Low. Yeah, so I hope you will get more spirit today as we have a distinguished guest with us. He is Onno Akerman, a pulmonologist from University of Groningen, the Netherlands. Maybe you are curious, how can Netherlands still have TB patients, right? Because I think the prevalence is less than 10 per 100,000. The prevalence of
Even less than 5.
even less than 5. So yes, they mostly get their patients from migrant or asylum seeker, but he will tell you more about it, of course. So Onno is a pulmonologist there, and he is a TB expert. There they have a special TB hospital, dedicated for TB, and he will tell you more later about that. But besides being a very good TB expert, he also being a very good, how you call it, not farmer, but farmer, you call it
Amateur farmer.
amateur farmer, because he has 6 cats, 10 sheep, domba, 10 sheep, and 9 chickens. It's a quite nice combination, isn't it? TB and those animals. So yeah, we will welcome Onno, and please give your applause for him.
Thank you so much for the kind introduction. And thank you for the invitation, and thank you for allowing me to be here and to give you a presentation about TB, and especially about the treatment and and the contribution to TB elimination. So this is my hospital. You can see it. Yeah. You can see it here, and you can't see my TB center. It's behind the other participants, but it will be shown later. Perhaps you can remove the other ones, yes.
Yeah, remove the...
Otherwise the slides won't be seen.
And we can use the pointer. Maybe in the middle, that's the pointer. Is it? No?
Oh, wait.
Pointernya yang mana?
Oh, no, that doesn't work on the screen, I think.
Ah, pointer doesn't work?
Kalau di layar memang tidak bisa.
Oh, only here. Yes.
Yeah.
Okay, okay.
It's okay.
Okay. Okay. Okay, it's okay.
Now we've left the screen. Yes, okay. And as Dr. Morita already told you, we have a specialized TB center, and in the 20th century, in the 19th century, it was very normal to have TB sanatoria, where the patients could stay for a longer period, because they had to keep bed rest for all the time, rehabilitate afterwards, and should eat healthy food. Was natural ventilation because high ceilings, but also open windows even when it was colder outside. And at that time, before TB medication, everybody was treated in the TB sanatorium. Nowadays, most persons will be treated at home because it's an uncomplicated treatment. The treatment is known for almost 50 years now, and most of the national TB programs, they provide food support as well to make sure that everybody's taking enough food. And so that's actually very well done. But still, in countries like mine, with low TB prevalences, we have certain cases, or what we call the TB outliers, both medically but also socially. More difficult to treat, difficult to reach, difficult to find, and because there are such specific cases, there should be individualized treatment based on the medicine, but also to look at rehabilitation, physical rehabilitation, and be provided with nutritional support, because most of our patients are malnourished, clearly. And also there should be attention for mental well-being, because when patients are hospitalized in a setting like ours, in our specialized TB center, many things are possible, but it's not possible most of the times for families to stay with their relatives who are admitted, though most of our patients, they don't have any relatives or family in our country, so they're alone. And this is a little bit of a photograph of the beginning of the 20th century. You can see everybody was laying outside, windows are open, even if it's winter, and fresh air was important, enough sunlight was important as well, and people weren't allowed to get off bed. And when it was really sunny, everybody was moved outside to get more sunlight because of the vitamin D and the immune status. And as you can see on this photo, this is the ward for the male patients, and they're lying outside, all of them together, but still only in bed. And this is a warning sign from that time. It's in Dutch, but it says already that you have to be careful when you have complaints or when you're having TB, that you couldn't spit or produce sputum for everybody's in everybody's face or close around, because it could be contagious. You could transmit the TB, so it would be a real public health threat. So this is actually my TB center. and it's not so large as most of the hospitals, and you can see a quite new building with a green roof on top of it. And it's like, how would you call it in English, the right shapes, water shapes.
Mm-hmm.
Yeah, so that's the TB center. The rest of the building looks quite old, it is quite old. It's 60, 70 years old already. And it was built as a TB sanatorium, a specific TB sanatorium in the 1950s of the last century. But then at that time, people were becoming treated at home with medicine and they could go home. So there wasn't need for a large TB sanatorium anymore. So not only TB patients were admitted, but also patients with COPD or asthma to rehabilitate. And the decrease in incidence of TB continued, so we only needed a specific center for TB in the Netherlands. And this is how it looks from the outside. So only one floor, so everybody stays at the same floor, which is because it's cheaper than 2 floors, because also you need healthcare staff. And this is how it looks if you look at a mapping. It was built on it, and it's the place where the green roof was. And if you go into more detail, you can see the brownish rooms, but also the more yellowish rooms. The more yellowish rooms are for the patients who aren't contagious anymore. So it's, for example, also pulmonary TB or with social related problems. And the brownish rooms are for the patients who are contagious and other issues that might be warranted to keep them in that part of the hospital. It's a 30-bed center, so we have only 30 beds for patients with TB, but we don't have so many patients all the time because it takes time, and you can see they're all on the outside, large windows, so we can still keep the sunlight, given the idea of being outside. And as mentioned, 30-bed center, it's state-of-the-art, at least in our opinion, from medical point of view, but also from hygiene aspects and social demands. All kinds of patients, physically really ill, but also mentally ill. In the Netherlands, as Dr. Morita told you, we don't have that many TB patients anymore, and there are lots of migrants coming, also asylum seekers, so many different backgrounds, cultural backgrounds, different languages, and all. But apart from that, also very different social backgrounds. So some are homeless, some are users of illicit drugs or of alcohol, and some are contagious, and that might be the only reason to be admitted. But for sure, most of them will stay for a longer period with us. A normal admission to a hospital in the Netherlands for a normal disease is between 5 and 7 days. At our place, it's between 2 or 3 months median. So our staff has a high expertise in cases like this, though it's declining a little bit because all the old staff members are retiring, but they're still dedicated. And clearly we should treat patients, but we also have a role in national and international education and research. And this is how it looks when a patient is admitted. It looks very nice, and our building, we think it's really nice, but people just feel isolated, and they're alone, so nobody there. They can leave the room short, wearing a mask, but still, it's a difficult time for them. And that's our contribution to TB elimination, and it's part of the title as well for the treatment. So I have a question for you, and we can use the Menti.
Mas, kodenya berapa? Kodenya? We will tell the students of the code. Masuk ke Menti ya, nanti ya, menti.com, masukin kode itu. Oh ya, Yeah. So that's the code they need to.
Yeah. So the code is on the screen. 62182401.
Oh, very good eyes.
I can see it over there.
Yeah. Oh, that's
Yeah.
very good eyes.
And then you can see how is everybody having the code already? This might even be
Or
better.
scan this. Oh,
Yeah, or scan this QR code.
I'll try.
Everybody having the code, then we can go to menti.com.
So, not connected to internet.
No?
Wait. Bisa? Bisa? Oke. Dapat pertanyaannya? Nyambung, bisa nggak? Oh ya, they got it.
Okay.
Nah, belum Mas, yang nomor satu dulu.
So you can see what's the definition of TB elimination, and there's one person per 100,000, one person per 500,000, one person per 1 million, or one per 5 million.
And most of them choose per 100,000 or per 1 million.
Yeah. So can we go back, please?
Go
Yes.
back to the slide.
Yeah. And I think all of you already filled in the questionnaire because we have 13. Yeah, so it's either one per 100,000 or one per 1 million.
1 million.
Okay, can we go back to the slides from the presentation, please? Then you can see the definition is actually one incident case per 1 million. Yeah.
Bravo tuh yang benar.
Yeah.
Cuma salah 0 ya, kurang 01 ya.
So a little bit about the epidemiology of TB for probably already well known, but recently the global TB report from the WHO was published, and it showed that 10.8 million people fell ill from TB, an estimated 10.8 million, and there were only a little bit more than 8 million registered cases. And from those 10 million, there was an estimated 1.3 million deaths due to TB or with TB. And to treat that well, all those cases for TB, WHO has operational handbooks on TB, both for drug-susceptible TB, but also for drug-resistant TB. And it's recently updated and a lot of new knowledge known. And I will discuss a little bit more about the backgrounds of that knowledge. So we started the drug-susceptible TB because that's the most easy, or it was the most easy one. But it changed a little bit. Standard regimen, as you know, 6 months, 2 months of an intensive phase and 4 months following of a continuation phase, 2 months of rifampicin, isoniazid, pyrazinamide, ethambutol, followed by 4 months of rifampicin and isoniazid. And they're looking already for many, many years, how can we shorten the duration of the treatment? So instead of 6 months, can we go to 2, 3, 4 months? And till now, till recently, previous studies didn't show any benefit from shortening the treatment, and it was rather non-safe compared to the standard care. And this is a study a couple of years ago already and published in 2021 in May, and it was based on rifampicin. It's also rifamycin, like rifampicin, but it's another one highly effective. And they did a 3-arm study comparing rifampicin, isoniazid, pyrazinamide, and or moxifloxacin or ethambutol for 8 weeks, followed by rifampicin, isoniazid, and either ethambutol or moxifloxacin for 9 weeks. And they compared it with the standard line, first line, as I explained, for 6 months. What I saw, the intervention is that the group containing the moxifloxacin, rifampicin, isoniazid, and pyrazinamide group, followed by rifampicin, isoniazid, and moxifloxacin, was the best, better than the other one with ethambutol. And they compared it with the standard care. And as you can see, the cure rate, which is the second row, is the same for both groups, which is great because now you can treat for 4 months, and there was a high certainty of evidence. And as you could see, adverse events were more or less the same as well, which is also always a worry because what does it cost success? So in this case, it didn't take so much or even less than the standard treatment group, the same for the all-cause mortality. So the conclusion is that the 4-month rifampicin-based regimen, together with moxifloxacin, was non-inferior, because that was the goal of the study, to the standard 6-month regimen, and it's included in the new WHO guidelines already, as you can see, but also in the CDC, the Center for Disease Control guidelines of the US in 2024. And so you can use it for people with TB older than 12 years and drug-susceptible pulmonary TB in this case. They also did a study in children, adolescents. It was an open label study, phase 2 or 2-arm study, non-inferiority trial, also for 4 months, but in this case 16 weeks instead of 17 weeks, and they compared it with 6 months, in this case 24 weeks. So 2 months or 8 weeks less than the standard of care treatment. And then there were children with non-severe, symptomatic, and presumably drug-susceptible with smear-negative TB. And this is a table with the results, and as you can see, treatment success was comparable between both arms. And adverse events were more or less the same as was treatment adherence. And they said 4 months of anti-TB treatment was non-inferior to 6 months in children with proven drug-susceptible TB, because that was in the end everybody was drug-susceptible, but they can't have severe TB. So it's based on the standards that the children have non-severe, in this case also smear-negative pulmonary TB. Clearly, after publication of this study, that was also included in the WHO guidelines, that it should be a consideration, and this was actually a strong recommendation to treat the specific group of children with only 4 months of treatment. But the same was for the American Academy of Pediatrics. So this is for the drug-susceptible TB. Finally, after 50 years, there are some changes that we can shorten the treatment duration from 6 months to 4 months, those still in specific groups. But it's hopeful. And rifampicin, that's the game changer for now, the combination with moxifloxacin, but in some countries, rifampicin is not available yet, or not accessible. Like in my country, we don't have access to rifampicin yet, so we still have to treat all our patients for 4 months, which is not good news for them. Luckily, for the drug-resistant TB, things changed as well. And the last couple of years, and the most recent WHO update on their handbook for treatment was in 2022, based on several studies, which I will discuss in a minute as well. But we have a new Menti question, and that is, what percentage of people with drug-resistant TB receive appropriate treatment? Is it 30, 40, 50, or 60%? You can show here the percentages. So A is 30%, B is 40%, C is 50%, and D is 60%. I think everybody already accessed the code, so perhaps we can see the Menti score.
Mas, yang kedua, slide kedua harus Mas ini, Mas apa? Mas present biar anunya questionnya keluar. This is still the previous question. Biar pertanyaannya keluar, yang slide kedua harus Mas present dulu itu loh. Present. Yes. Coba di anu lagi ya. Di load.
Okay.
Ya.
Yeah.
Sekarang udah keluar
Now you can
pertanyaannya.
choose.
Yes. Now we can choose. I know the answer, so I should not choose.
Only one yet.
Yang lain masih nimbang ya. Berapa
I
ya?
think everybody has the code already, right? Or no? Have you seen the results?
Mungkin hasilnya sudah keluar.
Great. Everybody answered. And there's no really consensus because it is divided very well. So can we go to back to the slides? Yes. So the correct answer is B, 40%. Only 40% is receiving appropriate treatment for drug-resistant TB. So 3 out of 5 patients is not receiving the right treatment for their TB, which is a huge problem because how many people are there worldwide with MDR and RR TB? In 2023, you can see here the dots are the countries with drug-resistant TB cases. The larger the dot, the more patients. And you can see that there are lots of cases in sub-Saharan Africa, but also in Southeast Asia and former Soviet republics. And there was a decline in the total number of patients with drug-resistant or MDR or RRTB, but the last couple of years it stabilized around 400,000 per year. And those are with the group of no previous history of TB treatment. So only 3 to 4% of the people with no previous TB treatment had a recurrent TB with MDR TB, but those with previous treated, about 20% had an MDR or RR TB. So that's a really big problem for those who were previously treated already. And as you can see, this is the evidence that it's only 2 out of 5 with drug-resistant TB assessed treatment, appropriate treatment. So that means that that more than half of the people annually don't receive the good treatments, and if they're contagious, they can still transmit the MDR TB, and that is a really huge public health crisis at the moment. So we have to do something about it. And what can we do? is, for example, improve treatment and make the treatment more accessible? And that's the next question.
Siapa nih yang beruntung?
Yeah, this is correct right now. So the question is how long is the treatment duration for our MDR-TB? Is it at least 6 months, at least 9 months? Good.
It's nice actually, yeah. With
Yeah,
this
that works very well. I think everybody scanned the code, so we can go to the results. Sorry, can you show us the results?
Hasil apa votingnya?
Yeah. So most of you think it's at least 9 months, but a substantial part is at least 6 months. That's increasing, and in every good TB, there should be one outlier, which we have today as well for at least 24 months. So perhaps you can go back to the presentation. And it's at least 6 months. And I will show you a little bit why. Because it's improved a lot. Yeah, I know, there's a surprise. That's very good. It's a pleasant surprise. Because it's only 6 months or longer. So that's changed a lot. So I'm glad I can tell you something that you don't know yet.
Yeah.
And it's based on some of the studies I will present to you. The first one is published already 4.5 years ago. It was a really landmark study because it was the first study for people with highly drug-resistant TB, and they looked at 6 months of treatment with 2 of the 3 new drugs, bedaquiline and predominate, together with one of the repurposed drugs, which is linezolid. And they saw that there was a very high treatment success of almost 90% for the patients with XDR and MDR TB. They still gave a very high dose of linezolid, which caused a lot of problems because everybody was experienced some adverse events. And as I said, it's a milestone because it was the first time drug-resistant TB could be treated with only 3 drugs for 6 months. It's mentioned. It's taking its price for the adverse events, mostly due to the linezolid. So they did a follow-up study, which was published 2 years later, and then they had 4 arms, still with bedaquiline and predominate, 2 new drugs. And now they have 4 arms with different duration and different doses of linezolid. So 600 milligrams, either 9 weeks or 26 weeks, or 1200 milligrams, 9 weeks versus 26 weeks. Treatment success rates were between 84 and 93%, so changed a little bit. And adverse events from linezolid were much lower. These were serious adverse events, much lower than expected. And they said, when you look at the treatment success and take into account the toxicity, then 600 milligrams linezolid once daily for 26 weeks was the most optimal treatment regimen. And I didn't put in it, but actually nowadays they already have studied that also 300 milligrams of linezolid is an option for 26 weeks, with even lower adverse events. They also published around that same time, a little bit later in 2022, in December, also another treatment regimen for rifampicin-resistant TB, 24 weeks, as I mentioned. There's always a difference in interpreting the amount of weeks compared to the months. Most of the times we say 6 months, and some say it's 24 weeks, and others say it's 26 weeks. In this case, 3 arms for 24 weeks, betacolin, predominant and linezolid, the same combination as shown before. Betacolin, that's the combination together with moxifloxacin or with clofasamine. And in this case, they found a treatment success of 77% for the so-called PPAL regime. And when you added moxifloxacin, the success rate increased by 12%. And if you added clofasamine, the treatment success increased but a little bit less. So after this first stage treatment, they continued with the second stage, and they compared the most successful combination of people together with moxifloxacin with the standard of care for 9 to 24 weeks. And in this case, they found a treatment success, and you can't see it, I think.
52%.
Only 52%, which is extremely low compared to the treatment success of the people and the people M machines.
Oh, bukan tadi slide yang tadi cuma apa ketutupan recording tadi loh. Ketutupan tanda itu tanda recording. Ya, sip.
Yeah. So as you can see, only 52% of success with the normal regimen, the standard of care regimen. So clearly they said this is the new regimen we have to give to most of our new MDR or our TB patients if access to both betacolin and predominant. But it's changed a lot, and you can see treatment success rates are much higher than we used to have. It's not working.
Yeah. Huh?
Yeah, okay. It's not published yet, but the WHO communicated about the BTB regimen in South Africa. 6 months regimen with betacolin, linezolid, and levofloxacin and clofasamine. And as soon as the drug susceptibility testing results of the fluoroquinolone loans became known, either continue with levofloxacin if it was susceptible, and if it was resistant, one could continue with clofasamine. And this study is great because it included children, adolescents, and also some pregnant women. There were no official safety data yet on predominant, and only using in less than 1 month exposure to one of the drugs for the patients. 5 different and it was successful, and I think I missed the extra slide, okay. And there was also another trial, the NTB trial, 5 different 9-month regimens, different combinations, betacolin, linezolid, levofloxacin, or moxifloxacin, both later generation skinolones, clofasamine and pyrazinamide, and combinations of treatment regimen. The treatment regimens were a combination of these drugs. And 3 of those 5 regimens were more effective and safer than the 18-month standard of care regimens. And those were the betacolin, moxifloxacin, linezolid, and pyrazinamide. And that was the first one to choose. Second one was betacolin, linezolid, levofloxacin, clofasamine, and pyrazinamide. If the first one couldn't work or didn't work, then you could go to this one. And if both of them didn't work, then the last one is also the preferred hierarchy from the WHO. And you could use betacolin, linezolid, levofloxacin, and pyrazinamide. And as you can see, delamanid instead of predominant, because delamanid is the other of the 3 new drugs. And we really hope that using short treatment regimens, it improves TB adherence, and it improves, and as you could see, for sure it improves treatment outcome rates. So we hope that the NTB strategies will be reached a little bit earlier, though the targets set for 2025, 2030, or 2035 are not by far not reached yet. And these are some of it showing what we want to reach in 2025 and how far we are at the moment. And you can see most of the percentage in 2023, we haven't done that. So the same for the United Nations targets to end TB. It's treatment coverage. I already showed 2 out of 5 is only receiving the appropriate treatment for MDR-TB. In general, overall, it's only 75. The TB preventive treatment, which is also a very important pillar of the MTBE strategy, is only for 56% for people living with HIV, and only even much less, 21% for the household contacts. Rapid diagnostic tests, because we have to know that a diagnosis as soon as possible is only halfway. So it's we are for sure not there yet. And how can we improve? Clearly, there is a large problem of funding for TB, not only for research, which is still a lot more needed than that is available, but especially in care, also for TB prevention, diagnosis, treatment. There is a gap of almost 60 billion US dollar, which is a very, very large amount, and which means that we are for sure won't be there in time if we continue like this. So there's a big and huge public health challenge in front of us. And with that having said, I would like to thank you for your attention, and the floor is open for any questions. Thank you so much.
Thank you so much, Dr. Onno. So, probably any question? Oh yeah, that's great. Lisa.
Excuse me, Dr. Akerman. I would like to ask some question. For the first question, would be what would be the challenges faced by the Netherlands in eliminating TB? As we know that Netherlands is one of the advanced country. So what is the challenges you face there? That was my first question. And my second question would be, is it necessary for us to also examine the strain of mycobacterial TB before treating the patient?
Can you repeat the second question? What was the
Is
last
it
part?
necessary to examine the strain of mycobacterial TB before we treat the patient? Thank you very much. That's all my question.
Very good questions, excellent questions. Shall I start with the last one? Because the second one is, I think, the most important for you. And to examine the strain, it might be the same, but what we really need to know is the drug susceptibility test results. And that's also part of examining the strain. And because it's clear, as I showed you, that we now have very good treatment regimens for drug-resistant TB, both for RR or MDR TB. And if we don't give them the right treatment for a longer period, they still might be contagious and transmit drug-resistant TB. So the sooner we have the drug susceptibility testing results, the better it is, so we can start the right treatment as soon as possible to prevent ongoing transmission by not treating the patient well. So in that case, I think it's really important. That's part of the examination of the strain. But that part, I think, is the most important one. We really need to know as soon as possible the DST results. So that's one thing we really need to know. And the challenge is the Netherlands face at the moment, how to eliminate TB is still there is, how do we reach the people who are at risk for having TB, developing TB, carrying with them TB infection. what are the last steps, is that we really should give the people with TB infection, try to give them TB preventive therapy. How can we reach those people having TB infection? That's the biggest challenge at the moment, because that's also funding is necessary. And as you said, we are advanced in TB elimination, but it's also going at a cost, because they say, well, it's a success, we don't have TB anymore, or hardly any TB anymore, so we can reduce the cost for TB care. And so all the good things that we started, for the continuation, we still need some kind of capacity. Then if they reduce the cost for the capacity, then we face another challenge. So that's always the challenge. When you're almost there at the finish, you still have to keep on going with all the stakeholders should be involved for all parts. Yes. So excellent questions. Thank you so much. Any other questions?
Thank you so much. Yeah, I think you got already the impressions. Yeah, the illustration, the differences between Netherlands and Indonesia in terms of the TB prevalence and how they manage TB. Even they can put all those difficult to treat TB patients to a sanatorium for some months, and there is funding for it. Well, in Indonesia, of course, we cannot do it. There is no place, and if there is a place, there will be not enough to many people. And we are still struggling so much in finding the case. Yeah. Even the active case, we have not yet talked about finding the contact is even more challenging. But even finding the active case is still difficult because of our remote areas and islands. In Netherlands, there is like one.
It's a very small country, so it's much easier to control.
Yeah. And here we have more than 17,000 islands, and most are in remote areas. So you can imagine the challenge, the difference. So yeah, that's very good question. Maybe another question is, I think some of you also comes from outside of Java, right? So even you can share your experience with him. Next week he will go to outside of Java, but for now he doesn't have any knowledge about outside of Java. So you can share your experience, and maybe some of you already worked also, right, in the health centers there as a program manager or whatever. So you can tell him how does the centers in outside of Java manage patient and everything. Please, who wants to share? You really need that knowledge, right? Nona?
Yeah. Who is from outside Java?
Oh, so time is yours. The other two, please.
Oh, no, what is this?
Where are you from? So that
Thank you. My name is I come from Bangka Belitung Island.
where is that located? Can you help me a little bit?
In north of Sumatra
Okay.
Island.
Yeah.
Bangka Belitung is 2 islands. It makes 1 province. Okay. My question is
Oh, okay. After this question, you can share also, yeah.
about TB case in Bangka Belitung. It's not more because it's not like in Java, more case, but in Bangka Belitung, it's a little bit case about TB, tuberculosis. But now I want to question about how about payment in Netherlands for treatment, because in our country, the treatment of TB is free from government. What about in Netherlands? And about also sanitarium, of all the payment is covered by government, or we must payment by ourselves? The second question is, you said that the prevalence of TB in Netherlands is there are multi background. What it means that immigrant that give the prevalence about TB, or it's pure from Netherlands case? I mean, migration case or pure from Netherlands case about TB? Thank you, sir.
Okay, excellent questions as well. Thank you so much. Multicultural background. Multicultural background is mostly due to the variation of migrants and asylum seekers. Some 80% of our cases are foreign-born cases, so they're migrants or asylum seekers. And why it's so important? Because it's also the challenge to find these active case finding. It's not only a problem in Indonesia, but also in our country, though we have much less cases. But these issues are a large issue of migration. It's a big issue in Western Europe at the moment. So our government, they don't really have good plans for people looking for migration to the Netherlands. That makes it even more difficult to reach those people, giving them good healthcare. And that touches upon your first question as well. So if they have TB disease, as soon as people entering the Netherlands, they need a health insurance company. So it says everybody is paying a certain amount of money each month in the Netherlands. And our social system is in that way that in the end everybody's paying for each other so that it remains safe and everybody has access to healthcare. Sometimes the government needs to pay a little bit more, and clearly government pays also is contributing to the healthcare system. So for TB disease, insurance companies pay, but for the TB preventive therapy for our people, and as mentioned, the people at risk are the people who are homeless, substance abusers, but also the migrants, asylum seekers. They come with hardly any money, still having an insurance, but TB preventive therapy is not paid by the insurance company, so the people have to pay that by themselves. So that's the challenge, and that's the main problem at the moment, even if we want to give them TB preventive therapy. And also the testing for TB infection, it's not covered by the national government, but also not by the insurance company. So we ask them to test for TB infections, which they have to pay themselves, but we want that to eliminate TB. And we also want them to receive TB preventive therapy, though we know that reactivation risk is not so high, especially in a setting in the Netherlands. And we ask them, even if they don't have so much money, coming from all different kinds of backgrounds, we still ask them to pay their own TB preventive therapy. I think that's a very big challenge as well, and it's not a good example from our government how we want to handle cases like this. Is that answering your question? Okay, thank you so much. Any more questions? Any more experiences?
Thank you for your opportunity. Thank you for your great presentation. I think I'm from Japan. I have some experience in research in TB. In my opinions, not only the location and the findings, it's the challenge in Indonesia for eliminating the TB case. but also compliance with taking medication. Because as far as I know, the TB treatment is still at least 6 months for MDR-TB and 6 months for sensitive drugs. And it is also related with the resistance with other antibiotics and other drugs. I mean, the other supplement drugs, like maybe for the liver and others. So, what do you think about it? It is you have the experience for this factor in the Netherlands? Thank you.
Okay, thank you so much. Excellent question as well. I think we don't call it compliance that much anymore, but more treatment adherence. It's a small difference, is that treatment adherence, the definition is that we try to involve the person with TB or the patient a little bit more. So we try to be part of the treatment itself. We want to discuss with the person who needs the treatment and why it's so important. Compliance, it's a definition from before that it was more like straightforward from the healthcare worker to the person saying you need the treatment for 6 months, instead of how can we involve the person or the family or the caregiver to be involved taking the medicine. It's also why it's so important to have that understanding of the different definition is that it's changed during years, but also opinion of WHO changed and from healthcare workers changed as well. So since the 1990s, the 90s of the last century, DOT was introduced, so direct observed therapy from taking the medicine. And they say it's really beneficial to improve TB treatment result and to eliminate TB. But for sure, we know somebody's online. Yeah, somebody should. And for sure it didn't work, and we didn't decrease the number of TB patients. So they were looking at how can we involve patients more and to make them more, give them more autonomy of their own treatment. Instead of distrust, we try to give them trust for taking the medicine, but still have some idea of treatment adherence of the patients. So they introduced VOT, video observed treatment, or DAT, digital adherence technologies. So I think most of you use WhatsApp nowadays, right? So what you can do is either take a photo or make a video and send it to the healthcare worker, or just message, or there are now some apps related to treatment adherence, but you can also have like small pill boxes or small pill bottles that you have to open through an app. And then the healthcare worker or the healthcare system receive a message that somebody opened his pills, so you're sure that they took their medicine, or at least got it from the box. But in that way, people are more having more autonomy, and there's still some part of the people with TB who needs direct observed therapy, because adherence won't be 100% for sure, but we know it from other diseases as well. So for example, asthma and COPD, only 25 or 30% are taking regular drugs. And we have to take into account also the literacy of patients about health. So health literacy and how can we address the items are really important, also gaining just some attention in recent years. So I think we are changing our behavior from healthcare workers' perspective towards patients, and I think also the patient's behavior changed through that, and we should reach each other. And that, I think, in the end, treatment adherence rate will improve drastically due to this evolution we are going through now. But it still remains a challenge. Yeah, thank you so much.
Thank you so much for sharing your experience and also asking for a question. Maybe others also from, oh, okay, that's great. Thanks. You will, okay.
Excuse me, Dr. Antonia and Dr. Akerman. I would like to share my experience as general practitioner in Sumbawa Island. Excuse me. I am from West Nusa Tenggara. I've once worked in a remote area in Sumbawa Island, and since Indonesia is an archipelago country, as you know that there are so many remote islands in Indonesia, and one of them may be Sumbawa, and that would be on 2014. I worked there. So the people there has the strong belief that there is no TB. Whenever time the doctor explained the result of sputum, TB positive, and the result of the X-ray of finding the defect in the lungs, they wouldn't believe it. They would say that no, this is a black magic. So they would not take any kind of medication. So it's quite difficult to make sure that people that this is bacteria and you can eliminate it with only antibacterial. It is easy to treat, so people will believe it. So I got one patient. Their family said to me that I am one of the richest family in here, so it is impossible for me and my part of family member get TB. So they refused to get the medication, and then if I was not mistaken, it was like 6 months after that, the patient got excuse me, TB usus, how to say TB usus? Extra TB, but yeah, it happened in gastrointestinal TB, and that's on my that's my experience. Thank you.
Oh, nice.
That's excellent. Very good experience. Yeah.
Very good. And if I may ask, so how do you and other health worker usually do to try to convince them to, to believe that this is a disease, it can be cured by this anti-TB drugs? How you can make them convinced? Yeah, and you can ask them.
An extra question: do they go to? Because I heard in some places and in the world there are the so-called traditional healers. Do they have it at your place as well? Because I don't exactly know.
We have many here.
Yeah.
It has people there have a strong belief in traditional healer. They call it sandro.
Yeah.
It's like dukun.
Yeah.
They call it sandro.
Yeah.
Traditional healer. They believe it more than doctor. So they come to the traditional healer.
Yeah. No, excellent. Because last week there was the biggest TB conference, the global TB conference, so-called Union. Also here in Indonesia, in Bali, and I was at a session. Somebody from North India, from Ladakh, was presenting the same issue as you were mentioning. And what they did is, instead of trying to convince the people, they really invested time and energy in the traditional healer. So when somebody went to the traditional healer with complaints of cough or night sweats, of losing weight, they were saying, well, convince the people. We are strongly believe in the way and what you are doing and how you are doing it. But in this case, to prevent transmission, we would like to send them to a local healthcare clinic to do an X-ray and to see further. But they really try to engage the traditional healers in active case finding of TB. And actually it took some time, but it worked. At least they showed us the numbers that it was actually working. So I think that's really, I found it really interesting, because I think it's on many places in this way. And I think it's also, that's what we face from the different cultural backgrounds as well. So we also have patients, but also Dutch patients who don't believe that they're ill, etc. We saw it in COVID pandemic time as well. It wasn't TB, but they didn't believe they had COVID or something like that. So I think it's remaining a global challenge. And I think hopefully we can learn from each other experience in this, especially on items like this.
I would like to say that we got a lot of challenges. That's all. Thank you.
Thank you.
Thank you so much.
Thank you so much. Yeah. Okay. If there is no other question, maybe we can conclude this session. And we would like to thank a lot for you, Dr. Onno, for your very excellent presentation and to enlighten us on the update of TB treatment. I think this is like really the fresh from the oven data, yeah, with all those trials. And now we know that for drug-resistant TB, we can have only 6 months treatment. Even there is still just in the short communication by WHO, yeah, it's not yet widely applied. But yeah, now we have new hope for this treatment and also to eliminate TB. We hope it will be closer. Yeah, and but of course it needs our help also to advocate people around us, like the challenge that you have. We as a health worker need to bring the message to the people around us about TB and how to prevent, how to diagnose, how to treat, and also to advocate also about funding as much as you can. Maybe some of you are working in the funding organization, so we need your voice also to convey the funding body to give more funding for WHO for TB. Even in global fund, even though TB is the most killer, we only get not until 1/3. Yeah, it's very global fund is for funding for HIV, TB, malaria. Yeah, but the biggest proportion goes to HIV.
Exactly.
And, well, TB is the most the highest killer of between those three, but TB only get how many percent? 10% or something like that. Yeah, at least.
Low.
Yeah, at least we should get 33% at least. Yeah, but you know, things like. So thank you so much for your attention. Hope it will be beneficial for we all in eliminate TB. Bye. So we give a